like to welcome you again to our MSK Ultrasound Zoom meeting tonight. And we are so privileged to have one of our colleagues. He's the youngest, from my knowledge. And he is a very active, very dynamic person, from what I can see. And at a very young age, he has achieved a lot already. He has been the chairman of the Philippine Board of Rehabilitation Medicine and has served for 3 years, Mike, right?
2 years.
And so successfully done so many things. And he's also a fellow of the Philippine Academy of Rehabilitation Medicine. He's a diplomate of osteopathic manipulation theory and practice, a registered of musculoskeletal sonologist of American Registry of Diagnostic Medical Sonology, now called APCA. He was just recently promoted to Associate Professor of the De La Salle University Health Science Institute College of Medicine, and he is affiliated with other hospitals and clinics. To name a few, it includes Asian Hospital and Medical Center, In Focus, Athletics, in Peak Form. So he's very active with exercise, and that is the reason why tonight he will speak about ultrasound in therapeutic exercise, how these images would appear in the ultrasound when we do particular exercises. So, but before we begin, let's just pause for a moment and let's just have a word of prayer. Let's pray. Heavenly Father, we would like, Lord, to thank you for this beautiful evening. We thank you for this opportunity that we can come to you, to thank you for your grace and your goodness, for giving us life and strength to enable us, oh God, to learn together. And even though we are being challenged by these situations that is around us, we're so grateful, Lord, that you have preserved us. You have given us the opportunity to serve our patients, but at the same time, learn new things. And may this lecture tonight give us a new perspective of how we could approach our patients. Thank you for your grace and your goodness. In Jesus' name we pray. Amen.
Amen.
So our speaker for tonight is the one and only Dr. Michael Francis Obispo, MD, PTRP. So Mike, it's now all yours.
Okay. Thank you very much, Dr. Jim. You failed to mention that one of my favorite roles right now is being the servant of the servant, Dr. Jim De Castro. And also, I've been helping Dr. De Castro. Some of you know I've been helping Dr. De Castro as one of his tech support here at MSK US. And I always ask him if I could just continue being tech support, but he kept on telling me that I should give a lecture. So without further ado, I'd go ahead and this is just going to be a short lecture for many of you, and some of you have probably already heard about it. So I have nothing to disclose. And my topic today, as Dr. De Castro was saying a while ago, is on musculoskeletal ultrasound application to therapeutic exercises. I would like to acknowledge some of my mentors and some of the people who have inspired me on this endeavor. First of all would be Jackie Whittaker. So she wrote a book on ultrasound imaging for rehabilitation of the lobopelvic region. I've actually taken a lot of her work here in this particular lecture today. And also this is Michael Shacklock. He's the author of the Clinical Neurodynamics. So he's also the head of neurodynamic solutions that teaches neurodynamics to different physiotherapists and clinicians all over the world. And last but not the least, my very own mentor, Peter Esselbach of Ultrasound Solutions. He actually helped me in Australia when he taught me a lot of the applications of musculoskeletal ultrasound for physiotherapy. By the way, all of these three they're all physiotherapists. None of them are medical doctors. So when we were in rehabilitation, when we were being discussed, when we were talking about ultrasound, the first thing that comes to mind is always a therapeutic ultrasound. The one that the ultrasound, because it uses sound waves, it generates heat, and it does some micro massage, creating some pain relieving effect to the different joints and muscles. But of course, this has had to change in the coming years ever since I learned musculoskeletal ultrasound. So right now, there's a marriage between the two of using therapeutic interventions or applications using the diagnostic ultrasound. Now, the value of ultrasound is that it's a real-time, cost-effective view of internal structures, especially of the musculoskeletal system. And it has become a very valuable tool because right now you can have a dynamic images in this particular picture where you can actually see muscles and joints in motions. And this has become a very interesting point amongst physiotherapists and other healthcare practitioners. Now, most of us were used to doing ultrasound imaging. So that's what's called as ultrasound imaging, or UC. So that's where the radiologists or sonologists, they diagnose pathology. In rehabilitation, there's such a thing as rehabilitative ultrasound imaging, or RUSI. So that actually takes a look at muscle, morphology, and behavior. And this is done mainly by physiotherapists. Now, how did RUSI come about? So RUSI came about when it tried to discuss about discussing the core muscles or the trunk muscles, like in this picture. Now, it's a program that I've been conducting for a couple of years right now in Asian Hospital and some of my other clinics. It's the core control program. Now, the core program came about, and basically the RUSI came about because of the problem of low back pain. And as we know, that low back pain has always been at the top 10 of many disabilities and causes of absences from work, both in industrial and in third world countries. Now, in a study by Hodges and Mosley, they noted that back pain actually deactivates the tonic deep core muscles. They are the ones that cause postural contraction when a patient does different activities. And because of that, because there's a deactivation of your deep core muscles, it is the phasic superficial muscles that come into play. But these are not supposed to be contracting tonically, because if they do this particular role, then they would go into fatigue, and then your low back pain becomes a vicious cycle. Now, Hydes et al. Noted that the deficits, meaning the problem with the non-activation of the deep core muscles, they don't necessarily recover immediately after resolution of pain. And it is also not addressed with traditional exercise programs that we have in physiotherapy, wherein you do increase in strength and functional capacity. Now, another problem is that many clinicians, when they hear about low back pain, they only think about the spine. So mostly they have this particular image wherein you have a stick man. So you have the head, arms, and trunk, and then there's a stick here. So that's a spine. And then there's the pelvis and the lower extremities. But we're not a stick. More so that there's a cylinder supporting the entire hat, or the head, arms, and trunk. So it's not just a stick there. So it's more of a cylinder that we have to look about. And that's what the core muscles are. Now, your core muscles are composed of, from the cranial portion would be the diaphragm, and in the caudal portion will be your pelvic floor. At the anterior portion and on the lateral portion, you will have the transversus abdominis muscle. And of course, at the posterior portion, you will have your erector spinae, most especially your multifidus muscles. So these are all your deep core muscles. They cause they act on tonic contraction to providing posture of your muscles. Now, you can have an analogy that the spine can be like your tent pole, and then your muscles are like your guy lines, and then the myofascial layer will be your tent fabric. Now, if there's no coordination between the guy lines, the metal pole, and even the tent fabric, then there will be dysfunction, and thus this will be seen in the patient as low back pain. Now, let's take a look at how we do an evaluation of the core muscles. So this is an evaluation of the transversus abdominis muscle. So you have the superficial layers, the external oblique, internal oblique, and the transversus abdominis. So this is what it looks like in ultrasound. So when we ask the patients to contract their abdominal muscles, I'll show you later on how they do these particular contractions. You will see the different layers. This is the subcutaneous tissue, external oblique, internal oblique, and the transversus abdominis. For the multifidus, we look at it on a long axis and a short axis. For the long axis, we try to find the facet joints. Okay. And then when we evaluate the multifidi, you will have a superficial layer and a deep layer. What we're more interested in is actually the deep layer. So we take a look at how the contraction of this deep layer undergoes. And of course, we can look at the multifidus in different spinal levels. So this is what the multifidus looks like in a short axis view. So you have the spine and the lamina, then the multifidus is just on top. Now your pelvic floor muscles, you also look at them in a long axis and a short axis. So in this particular picture, so this is the rectus abdominis, this is the bladder, this is actually vaginal wall, and this is the pelvic floor muscle. Okay. Now this is what it looks like in ultrasound. This knob here that we're seeing in this picture, this is what we're interested at, because it's the pelvic floor muscles, and then if we ask the patient to contract the pelvic floor muscles, this knob here would go inside the bladder. So it will go superior anterior. Now we can also look at the pelvic floor muscles on a transverse view. So you have the bladder, and then the pelvic floor muscles are at the side. So on ultrasound, it's going to look like this. So this is the bladder, anechoic area. This is actually the prostate, okay? And the pelvic floor muscles are on the side. So when we ask the patient to contract, sometimes we have to evaluate whether it's how patent are both sides. Are they contracting well, or is one side dipping more than the other? Now let's take a look at some pathology. So this picture on the left here would be a picture of a fascial insufficiency. So the fascia, it's not too tight. Therefore, when the transversus abdominis contracts, then it's pulling all the way back. Now this one, the one on the upper right, this is more common. This is where the internal oblique is hypertonic, and the transversus abdominis, it is hypotonic, so it doesn't contract too much. And then we see that the one that's contracting more is the internal oblique. So this is very common with a lot of patients. However, I've seen also some patients that don't have low back pain. They're used to using the internal obliques a lot. So I'm not sure that this would really correspond that it's a cause of your low back pain. Another pathology that we can see in ultrasound is when we ask the patient to contract their pelvic floor muscles. So instead of the knob going inside, then it dips down. Okay, so it's being depressed. So it means there's an incoordination of the patient when they're trying to contract their muscles. Now, in treating patients with low back pain using the ultrasound, there are two concepts that we take it in mind. One is that exercise is medicine. Of course, we've heard a lot about the exercise of medicine objective from our cardiovascular friends, from our internal medicine friends. They actually, this is more actually used for patients with metabolic problems and cardiovascular problems. But of course, also in terms of pain management, there's also a role for exercise. Another thing is that when we use the ultrasound for exercises, we have to remember that what we're using is a biofeedback. So it's actually training both your central nervous system so that there's motor reprogramming of your muscles. And that one becomes an automatic function later on. Now, for the core control program, the objective is actually to retrain the deep core muscles. So this involves preventing the hyperactivity of your superficial muscles. What you want to train more is the deep core, and then you want lesser activity from the superficial muscles. Another is that we have to focus on pre-activation. Let me expound on this. If you've tried lifting an object from the floor, a very heavy object, let's say a barbell, okay? So before you try lifting, you're probably noticing that your core muscles are bracing, or you inhale deep and then you brace your core. So that's a form of pre-activation. So that's what the core control program is. It also goes into focusing on the pre-activation before certain activities are done. That's actually to protect the back and especially the spine. And of course, lastly, is that the role of core control program is to incorporate all of these exercises or all of these tasks to functional tasks. Now, the first maneuver that's being done for the core control program is what we call the abdominal drawing in maneuver. So usually we just have to tell the patient to do a stomach in. Okay, so you draw your stomach in, and we ask them to hold probably a couple of seconds. Probably at the most would be 3 seconds. And this is what it looks like on ultrasound. So when we ask a patient to contract or do an abdominal drawing in maneuver, this is what they do. So they actually contract both the superficial muscles as well as your transversus abdominis. But in the core control program, of course, we want lesser activity from the superficial muscles, especially the internal oblique. So on the picture here on the right, as you can see, look at that. It's mostly the transversus abdominis that's just moving. That's going to be the role of the ultrasound, because you have to tell your patients, okay, if you see this picture, then they're doing it wrong. But if they're doing it on the right side, they're just having some minimal contraction from the internal oblique and more contraction from the transverse abdominis, then that's the correct task that can be done. Another activity that we can ask our patients is by doing a pelvic floor exercises. And you will be probably familiar of the Kegel's exercise, wherein we ask the patient to hold their pelvic floor. Okay? So as you can see, if they try to hold their pelvic floor, the pelvic floor muscles go up, then they tighten up. Okay? And for this one, we would want to go back to the bladder. Let me go back to my picture of the bladder. So this is a picture again of the bladder. So when they contract the pelvic floor, we want this knob here to go inside the bladder, not become depressed from the bladder. Now, this is another activity that we do, especially for the multifidus. This is the most tricky exercise to instruct your patients, because obviously we don't ask them to do this particular exercise. This is called the Superman. Instead, what I usually do is that I show them this picture and I tell them to visualize it. I tell my patients, visualize it, but you're not supposed to move your arms or even your upper back. So the result would be is that the patient would feel some tightening of the lower back. So it does get tricky, and sometimes you need to be creative in how you will be instructing your patients on how to assess the multifidus. Now, the thing is that once you've taught the patient these individual exercises, then you need to have them contract all of these muscles coordinated fashion. So you need to have the abdominal wall or the transversus abdominis contract, the pelvic floor muscles contract, the multifidus contract, and it should be coordinated with the breathing done with the diaphragm. So for some patients, the coordination problem becomes a problem. But that's why we put them into training. That's why it's a motor relearning program. Now, of course, after we've done these exercises and we've already taught them how to coordinately contract these muscles, then we challenge them. So this is spinal loading. So we do the exercises. We ask them to do straight leg raises. And we can check if they are able to still do the correct pre-activation of these muscles and to lessen the activity of the superficial muscles in these activities. And then if they've graduated from that, then they can do functional tasks like this one. In our particular clinic, we have weights, and then we can use the ultrasound or portable ultrasounds in the clinic to see if they're doing their contractions and their exercises correctly. Now, in terms of effectiveness, of course, our researchers would show that ultrasound imaging showed better reproducibility in performing abdominal drawing-in maneuvers with lesser number of repetitions to perform effectively as compared to verbal and tactile feedback. Of course, because since the patient is able to see the image in the screen, then they don't only have the verbal and tactile feedback to work on, but they also have the visual feedback to work on. And the visual feedback allows them to modulate how much contraction their muscle should be conducting. Another study by Smith showed that there is strong evidence to support that stabilization exercises only help in the short-term management of low back pain as compared to regular exercise. So if you're going to ask me, is this going to be helpful in the long term? Probably not, because it doesn't really address long-term disability. So of course, this training management for the core, they can also be applied to other muscles. And this is my teacher, Peter Esselbach, and he's applying the program at the back muscles. So this is a patient with a myofascial pain syndrome, and he's actually looking at the patient, looking at the upper trapezius, looking at the rhomboids. He's checking if there's hyperactivity of either the rhomboids or the upper trapezius. Mostly it's the upper trapezius. And he wants more engagement of the rhomboids. And because there's some interest in myofascial pain syndrome and exercise to be done on that, of course, they've been looking into the utility of elastography. However, the utilization of elastography is still in experimental phase. So there's a lot of research that has to go into it before it can be used for our daily clinics. Now, besides being used for the upper back muscles and the core muscles, we can also use this for training the VMO. You can have the patient, you can just scan on the vastus medialis, and then you just angle your probe going to the patella, and you'll see the VMO here. So it's just a thin layer of muscle. But of course, can you train the VMO in isolation? What we usually do in the clinics, I'd say it's a flat out no. So you can't really train the VMO in isolation. So if you're going to train the VMO, the other muscles, your vastus lateralis, your rectus femoris, they're all gonna fire. So even if you put a pillow or a ball between the patient's legs, that's not going to further strengthen your VMO. But of course, it's a good tool still using the ultrasound to help your patients become engaged in your various exercises. Now, of course, since I started learning ultrasound along with Dr. De Castro, one of the more profound things that I've learned is in doing interventional activities. Like in this case, it's the median nerve, and I'm actually doing what you call a hydrodissection. So this has actually revolutionized a lot of the things that we do in interventional medicine, especially in ultrasound-guided intervention. But the question last is that, yeah, okay, I've done a hydrodissection of my patients. So what am I going to do about it afterwards? Am I just going to say, okay, just wait for it and whatever happens? Or do I provide them with some other activities? Of course, my training as a physiatrist and also as a physiotherapist has told me that whether your patient has undergone surgery or even an injection, you still need to send your patients for exercises, especially for physiotherapy. So what therapy can we do for these patients that we've done our hydrodissection? And that's where neurodynamics comes into play. What is neurodynamics? So neurodynamics, it's a form of mobilization, exercise, and positional treatment. And it addresses the interaction between the nerves and surrounding tissue. So that actually elicits a response that affects neural sensitivity. So the new pain science says that pain is mostly a matter of sensitivity. Now you can actually affect the nerve and its surrounding tissue by doing various positions and exercise like this one, and for the median nerve, ulnar nerve, and radial nerve. So how does it look like? So this is actually based from, I'd like to acknowledge my source, which is the Physio Tutors. But this is actually taken from another master of neurodynamics, David Butler. So he showed this particular method of how nerves slide or floss. Okay, so it's this actually simulating the median nerve coming from the neck and then goes all the way to your hand. So as you can see, the physio here, he's doing actually a lateral cervical slide. It's a slide because both ends are moving on the same direction. If they're moving on separate directions, then that's going to be a tensioner. But most of the effects in terms of neurodynamics, most pain relief actually happens when you do sliders instead of tensioners. So this is an upper extremity slide. In the same regard, you can also do it for your lower extremities. So this is actually an example of, look at the TheraBand. So it goes all the way to the neck, actually to the spine, then goes all the way to your leg. This is actually simulating your sciatic nerve. So this is a slide of your sciatic nerve. You're probably wondering, why isn't everybody doing this right now? Of course, it's more like a juggling act. So this is me. I'm actually holding a probe here, looking at the screen. I might have to move the patient's neck, and I have, while scanning and holding the probe into place, looking at the median nerve, I have to move the distal end. Sometimes I might need to move the elbow, sometimes I might need to move the wrist in order to see where the slide occurs. So it's more really of like a juggling act. So for some, they find that this is very tedious. So what does it look like in ultrasound? So this is actually the carpal tunnel. So you have the flexor tendons here, and this is the median nerve. So in this case, my subject here is just flexing the fingers or the IP joints. And as you can see, both the median nerve and the flexor tendons, they're sliding at the same time. Now, this is a case wherein I've put the wrist into a fixed position. And in this case, I just moved the neck of my subject. So if you can see, this is the flexor tendons. They're not moving much. And look at the movement of the median nerve. There's a lot more movement occurring here at the median nerve rather than the flexor tendons. And that shows me that there's a good slide in this particular patient. And you can also see the nerve at the pronator teres. I'd like to thank my mentor, Dr. Suarez, for pointing this out to me. So she actually showed you that, yeah, you can also see slides at the pronator teres. So you have the pronator teres here. And as you can see, this is your median nerve. Okay, there's some slide to it. Now for the sciatic nerve, it's usually best seen at the thigh level. So this is the biceps femoris, and this is the sciatic nerve. This is the femur. Okay? So this is where my subject is actually flexing the knee. So you can see both the biceps femoris and the sciatic nerve move at the same time. Now, if you start doing neurodynamics, wherein I've put the knee in actually in a static position, and I just move the foot. As you can see, the biceps femoris is no longer moving, and you can see that the sciatic nerve is actually sliding in and out in that particular area. So that tells me that's a good slide. So what if it's not sliding so well? So it's either the positioning is not good, so we either move, if not the knee, might need to move the hip, or you might need to differentiate the position. So the difficulty of that goes into this one where I'm trying to mobilize the sciatic nerve. The tibial nerve. Okay? So this is the tibial nerve here. Now, because I'm not getting a lot of slide when I was doing a movement of the toes, I was actually moving the knee. So I did get some slide when I was moving the knee and fixing the toes, or rather the ankle. Okay. So what does the evidence show in terms of doing neurodynamics? So of course, as I mentioned a while ago, so there's actually markedly different sciatic nerve excursions under ultrasound for neurodynamic techniques combining movements of the hip and knee. So you move them in different positions, so you'll have different varying nerve excursions. And then that's where you can work on your exercises or your neurodynamic exercises for these cases. Another is that there's grade A evidence that shows that cervical lateral glide techniques and straight leg raising techniques of neural mobilization are actually recommended to treat neck and low back pain respectively. And although many researchers are looking at the movement of the median nerve at the carpal tunnel, in terms of effectiveness, there's no significant effects for patients, for using neurodynamics for patients with carpal tunnel syndrome. So the question with all of these exercises and using ultrasound is always, what is the best approach? So for that, I'd go back to the clinical practice guidelines of the Philippine Academy of Rehabilitation Medicine on low back pain done last 2012. It's already updated last 2017. So in this particular table, it actually evaluates physical activity for therapeutic exercises for acute, subacute, and chronic low back pain. And it's subdivided into non-specific, radicular, and secondary back pains. Now, the ones in blue and in underline, that is strongly endorsed, that's the highest recommendation. So you can see that there is strong endorsement to remain active for non-specific back pain for acute, subacute, and chronic. But in terms of, and also actually for therapeutic exercises, there is strong evidence for non-specific back pain to be used at the subacute and chronic stages. However, the ironic thing here is that specific exercises are actually endorsed against. So you can see that they're all endorsed against on all levels. So what does this mean? So therapeutic exercises, strongly endorsed, and then specific exercises, endorsed against. So what's the problem? It's because the evidence, when this was first shown to me, I also was puzzled. But when I tried to look at the researches, it was showing me that no one exercise will help in your back pain. So if you say, is it going to be Williams flexion exercise? Is it going to be Mackenzie exercise? Is it going to be core exercise? No. So you don't stick to just to one exercise to help with your patients with back pain. So you need to do a group of exercise, and you need to tailor it actually for your patients. So the question always begs that patients are always asking, what is the best exercise? Of course, I tell them the best exercise, it's the one that gets done. Of course, if the patient doesn't do their exercise, then it's going to be useless. So definitely it's not going to be the best. And next is that the best exercise is sustainable. Of course, just like any medicine, you need to keep on taking it. You stop doing the exercises, all of the gains that you've gotten from the exercise, they will all disappear. And of course, the best exercise should be fun. That's because if what you're doing is not fun, then of course it's not going to be sustainable. And you're not going to be able to do it at all. And last but not the least, the best exercise achieves the desired result. This being said is that your exercises, your exercise program always needs to be individualized. And you always need to listen to your patients. So as I end my lecture this evening, I like to put on some points to ponder. First of all, always remember that pain has a multifactorial biopsychosocial element that modulates its intensity. And because it's multifactorial, it will require an appropriate multimodal approach. So if you're asking, will I just inject my patient and forget about it? You're wrong. You need to inject your patient. You need to send them for physiotherapy for exercises. And you might need to do some counseling for your patients as well. Because some of them, they have psychosocial issues that they want to tackle with. Or sometimes they just need someone to listen to. Another is that biofeedback is just one of the adjunct methods to be used for motor relearning. So we use so remember that even though you're using the ultrasound, it should still be in conjunction with other forms of therapy. And of course, in addition to the auditory and tactile cueing provided by the therapist, what the ultrasound imaging provides in terms of performing exercises is the visual feedback. And usually, remember, a lot of us are very visual. We watch TV, we look at the cell phone, we look at the type. A lot of us are visually oriented. So of course, if we stimulate our visual sense, it actually provides engagement. So the patients are more engaged right now in performing their exercises. So with that, I'd like to leave a message that in order to grow as a person, we need to get out of our comfort zones and challenge ourselves. Do what makes you uncomfortable, see how it feels, and learn to deal with it in a positive way. And I would like to invite you to like and follow us in my page. Actually, our page, this is Horizons. So it's a telerehabilitation page. We have resources, and we also share the Mask US lectures for those before Dr. Jim decided to share it in YouTube. So for that, thank you very much. So we'll go for questions. Hello. Yes. Is Dr. Jim there? Dr. Jim is not there. Any questions?
Hi, Doc.
Ayun.
Wonderful
Yay,
lecture po.
Jeremy.
Yes.
Thank you, Jeremy.
First time I've actually heard about biofeedback in action. No? I'd like to ask, Doc, how you do the sciatic nerve neurodynamics. What position do you do it?
Okay. This is done with the patient in prone. Actually, you can mix and match a lot of there's no standard way in doing these ultrasound guided exercise, because you have to have the probe placement. So that's an important thing. But for my subject, that what I did is that I placed my subject in prone position, and I was scanning the thigh, the back of the thigh, and I tried first to move the knee to see if there's gonna be some slide there. Of course, obviously, as you saw in the video a while ago, both the sciatic nerve and the biceps femoris were both moving. I tried. That's when I fixed the knee, and I was actually moving the. I was actually moving the foot, but if you still don't get a slide there, you might want to fix both the foot and the knee, and instead move the hip. Now, you can also try doing this with the patient in supine. However, it might be a little difficult, especially if you want to include the neck motion. You want the patient to flex the neck with the patient supine, and then you do a straight leg raising test. I have personally tried, and it's very tricky. It's more trickier than doing the upper extremity. So usually, if you want to use the ultrasound, you would want to do it with the patient in prone.
Thank you, Doc.
So there's a question from Pash. So the question is that when visualizing the abdominal muscles, is it better to have a full bladder? For the transversus abdominis and multifidus, you don't necessarily need to have a full bladder, but for the pelvic floor muscles, it will be better to have at least some fluids before you do it. Not necessarily full, because if the patient is squirming a lot, then it might be a little difficult to do the examination, especially if they feel that they're supposed to urinate already.
Thank you,
It
Dr.
will help you visualize it more.
This is very interesting. Thank you so much.
Mike, I have a question for you.
Yes,
how do you do, because of course we see also patients with sports hernia. So how do you go about strengthening these muscles as to maybe to some extent avoid a re-injury, or if not really injured, a new injury for that particular muscle?
Okay. Thank you very much, Dr. Jim, for that question. I know you're one of the country's expert on the sports hernia. From my limited knowledge of the sports hernia, it's mostly a problem with the adductors, and probably also with the obturator nerve. So the thing is that the obturator nerve is not really a very long nerve, although you can probably have some fibers going all the way to the knee, but they will be too small to really be seen in many of our patients. So at the most, we'd probably address the groin area. And for that, we will have just to do some adduction exercises. It's just to mobilize the nerve in that particular area. So there's not a lot of positioning, unlike, for example, the long nerves like your median nerve and the sciatic nerve. It actually traverses like 3 or more joints. So it becomes a little more tricky. But for the obturator nerve, so the only joint that it traverses is the hip joint. So it's just going to be fairly easy in that particular regard. So you can just do some hip adduction exercises. But of course, that's not set in stone. Sometimes you also need to experiment on doing some flexion or even hyperextension exercises for your patient. However, I've tried looking at the obturator nerve, and I haven't been able to see a slide in this area. I guess because some nerves you won't probably really be able to see the slide because they are tightly invested within the muscular tissue. So in these areas that they're tightly invested, then we're likely not to see the slide in these areas, unlike in the very long nerves.
Thank you, Mike. Any more questions from our audience? So I think Dr. Domingo here is asking something.
So his question is there a sport you can safely recommend for patients with low back pain and carpal tunnel syndrome that will incorporate neural mobilization? Actually, there's no special sport or exercise. Any of your all your activities will be they will already incorporate neural mobilization. What I usually ask my patients after I do a hydrodissection, I actually send them to a specialist therapist, because not all the therapists they know about neurodynamics. So I have to be very particular with my therapists. And it's actually my therapists that they already incorporate the neural mobilization in the training exercises. So it can be incorporated in probably in lifting activities or even in flexibility activities. Yes, Dr. Pash.
Doc, I have a question. How often do you repeat assessing the core muscles again? But you do an initial assessment, then you do some, of course, physical therapy to see if you're able to strengthen it. Is there a scheduling of when best to see if it's actually working, or it's more of a just case-to-case basis? Thank you, Doc.
Okay. When I started doing this a couple of years ago, I was trying to look for pathology, but however, sometimes I even see some of the abnormalities in normal individuals. So I already stopped looking for pathology for my patients. Now it's being used more as a teaching tool. So I show the patients, okay, there's a problem. Let's try to address it. If it improves their back pain or it improves their function, then we continue doing it. If it doesn't improve anything, then we stop, because of course it means it's not the appropriate activity, or it's not the appropriate exercise that we are supposed to do for our patients. But I would, for example, probably for neurodynamics, I do one session just to find out where the slides are, just to figure out what positions the slides are more effective. And then I take away the ultrasound and have them do these activities by themselves. With the core, in our institution, in Asian Hospital, we actually have our patients, we actually have them do it because they just do it as outpatient. So we have them do feedback every session. So it's just like 3 or 5 minutes for our patients. It's not really very long, so we have it done for them. And especially most of our patients in the outpatient department, they're all in the acute phase. So remember, the core stabilization exercises are very effective only at the short term. So it's nice to use all of these things at the short term, but then if the patients are having chronic back pain, then you need to find other means.
Okay, Pash, any more question? Okay, thank you very much, Mike. And
thank you.
I hope you enjoy our lecture tonight. And I would like to thank Mike for that wonderful lecture tonight. And we look forward to seeing you again next week. We have 3 speakers next week. We look forward to Dr. Yon from Korea, Dr. Summer Narosi, and then of course, Dr. Felice Galosio from Italy. So we have 3 speakers to watch out, and I'd like to ask you to wait for my announcement. I'm gonna post it. And of course, this lecture will be available in our MSK Ultrasound on YouTube for you to review, and the rest of the other lectures. So thank you very much, and hope you enjoy your sleep tonight. Thank you again, Mike, for that wonderful lecture, and hope to see you again next week. So God bless everyone, and take care.